How do I relay non-specific low back pain to a patient? Is this the diagnosis I should give someone? This is one of the most common questions that I get from physiotherapy students. Do I just tell my patient they have non-specific low back pain? Well, let's unpack this idea. Non-specific low back pain is the term that we'll see most often in the research, our clinical guidelines, and in communication between health professionals for the 80 to 90% of people with low back pain without an identifiable specific cause. Firstly, I want to start with this quote from UK physiotherapist Ben Cormick. Non-specific low back pain does not mean there is no tissue source of the patient's pain. It means you have carefully excluded red flags or specific sources of the patient's pain that can be reliably identified. Non-specific low back pain is about the inability to reliably tell what the tissue source is. Most importantly, non-specific low back pain does not mean non-specific treatment. This means that we are just not throwing our hands up and saying we don't know what is going on with our patient. We would have undertaken a really thorough interview and physical examination, so we have probably worked out several important contributing factors as to why someone has developed pain and is continuing to experience pain, whether these factors are biological, psychological, social, or a few of each. Finding a pathoanatomical source of someone's symptoms once we have considered red flags and specific causes of low back pain is probably not possible and not really helpful. So what do? I want to touch on 3 really important studies that, to me, provide some great guidance to where we can go here. The first is from Ben Darlow and colleagues in Otago, New Zealand. Through their qualitative research, they found that people's beliefs about their back pain is influenced by a range of sources, especially what was told to them by their health professional, with some information influencing their beliefs for many years. What I take from this is that what we tell people is important in shaping their beliefs about their own body and their future beliefs too. The second piece of research that can help guide us is from Lim and colleagues a few years ago in the Journal of Physiotherapy. This systematic review confirmed what many physiotherapists have known all along. People with back pain want clear, consistent, and personalised information about their back pain. So this means that what we probably thought already, we can't just brush over things with the patient and strategically skip past giving them diagnostic information. The last one is really recent and incredibly helpful. Mary O'Keefe and colleagues went one step further. In my years of teaching, I've found that students really feel that patients will want a specific tissue-based diagnosis and find it hard to not give the patient one. But when we look at patient preferences, there may not be the big issues that we may have first thought. This research looked at many patients who were given diagnoses by health professionals and looked at their preferences and how they viewed them. They looked at 6 different diagnostic labels, which are commonly used out in the community. They looked at terms like disc bulge, arthritis, degeneration, lumbar sprain, and also non-specific low back pain. The 3 diagnostic terms that were associated with the highest expectation for recovery from patients were lumbar sprain, non-specific low back pain, and the term episode of low back pain. These terms were also perceived as being less threatening and were associated with less need for a second opinion. So that's some of the research out of the way. Where do we go from here with our patients? So let's look at a scenario where we could think about the use of these terms. So we have a patient with acute or subacute low back pain who recalls a specific event, something mechanical that triggered their back pain. The term lumbar sprain might be helpful and appropriate here. We know it's perceived relatively well, and it probably fits with the patient's experience in having a sudden onset of low back pain. So you've undertaken the interview and the physical assessment. This might have uncovered some contributing factors, such as the triggering event, other aspects of loading, maybe some sudden or unaccustomed activity, and perhaps some psychological or social elements that are also contributing to their pain experience. Through your manual examination, you probably will have isolated a specific segment that's the main source of their pain. So we can ask the patient here if they know anything about the spine. They might know very little or a lot. So you can modify your plan to fit with their previous understanding. We can show them a model of the spine if you find this helpful. You might point out the number of structures around the lower back, or you might even mention that any or all of these structures can give pain. You can then be as specific as you think is necessary. You might point out the segment that you isolated in your manual examination and say that there's been a sprain to that segment, L5-S1, that this is a relatively mild injury where we can confidently rule out other causes of the patient's pain. Depending on the presentation of the patient, it may be helpful to outline other things that the patient would like to know or that you clinically reason as being important, or even start to address any unhelpful beliefs that the patient has. We can then go on with other aspects of our education, like discussing what the patient can do to help with their recovery, or discuss some of the contributing factors in more detail. But what about situations where someone has had an insidious onset of their low back pain? If someone's symptoms have come on slowly or gradually, telling them there has been an injury, like a sprain, is probably not accurate, nor does it fit with their experience. And this would be even more problematic if the patient's symptoms are continuing outside normal healing timeframes. In these situations, we can still be specific. We can isolate where most of these symptoms are coming from, perhaps down to a single segment we've isolated in our manual examination. We might refer to this as L5-S1 low back pain, for example, and go on to discuss the contributing factors as to why they're getting pain or continuing to get pain. In summary, you'll see we've gone nowhere near just brushing over someone's pain experience by saying you've got non-specific low back pain. We've been specific, we've been personalised, and the patient leaves with an understanding about what is going on with their back and what they can do. So let's look at 3 key takeaway points. Non-specific low back pain doesn't mean there hasn't been an injury. So we shouldn't imply this to a patient, especially where they've had a sudden and acute onset of their symptoms. Where a patient has had an insidious onset of their pain or outside normal healing timeframes, we need to avoid using injury-specific language where there hasn't been one. Lastly, don't brush over your diagnosis with the patient. Be specific about where the problem is, and importantly, what has contributed to their symptoms, and therefore is an explanation for their symptoms.